joining us today. While we're about to get started, this is our inaugural health equity brown bag lunch. So whether it's a brown bag or it's not, we are hoping to do these bi-weekly, and we have a huge special treat today because we have Rex Wong. He is our partner at UGHE and our colleague Owemba, who's with, and I'm going to let Rex introduce Owemba to you after I introduce Rex. But the plan for these brown bag lunches is twice a month, and this is again our first one. So is it okay if I introduce you? Will you start for that? Okay, great. Okay, I'm gonna read because I don't want to. Rex has like an amazing background, and I don't want to miss anything for compliments too. So officially, he's the director of the Bill and Joyce Cummings Institute of Global Health at UGHE, our partner in Rwanda. And is teaching the Masters of Science in Global Health Delivery program. So for those of you who are less familiar with global health, we often talk like there's global health research, but then there's the delivery of it. So how do the interventions or the potential solutions actually reach the people who need it? And for really policy, Erica's here, we have policy folks. We ordered a book for you guys by Joya Mukherjee on the introduction to global health delivery. So just to connect the dots, but Rex is an expert as well. Rex has over 28 years of hospital and healthcare work experience globally, and get this, guys: Liberia, Rwanda, Ethiopia, South Africa, Egypt, Australia, Qatar, Saudi Arabia, India, Hong Kong, the US, Panama, Trinidad and Tobago, and Tanzania on hospital management, national health systems, and senior leadership programs. And prior to his role at UGHE, he was at Yale as the director of Hospital Strengthening Initiative, and they're directed health management and hospital quality improvement projects, building local faculty capacity, and providing leadership training. So, and he did much more. So I'm not going to keep going, but I just want you to know that Rex is an incredible partner for us as part of the East Africa Biodesign program. Many of you know Nat and Gerard, and Nat is now back working with Rex and Owemba at UGHE. And today he is going to give us an introduction to UGHE, and I know he's going to give another talk, which you guys are aware of tomorrow. But what we're hoping today, Rex, if it's okay with you, is that this is kind of, you know, a warm audience. We may have a few questions, but hopefully this is a bit more of a discussion as compared to like you're just going to hear about UGHE. But feel free to ask questions. I'm volunteering you. Feel free to ask questions. And
here.
Yeah, because it is a lunch. So thank you. With that, I will hand it over.
You can use the.
Yeah.
All right. So I'm here not by myself because I'm at fourth here. Wimber is the coordinator for the Innovation Center at UGHE. He basically manages all the logistics, everything I can't do. He takes care of that. He takes care of that. So I can't go anywhere without him, actually. Oh, I can't go anywhere without his approval. So he's here with us today. And if you have any questions that you want to ask about UGHE, he can potentially also answer the questions. So when Megana asked me to do this presentation, actually two presentations. One is about UGHE, the other one is about for you guys, right? So for the bigger UGHE program, so I'm going to say it tomorrow. So I have a little bit introduction about UGHE today, but we want to spend a little bit more time to talk about the innovation area in low-income country, low and middle-income country, or developing countries for that matters. Because in terms of innovation around health in setting with no resources, the challenges can be a little bit different. Kristen, you set up multiple programs in Kenya before. You know, like the problem, we cannot just bring it back to US, or the solutions we have US cannot just directly transfer to countries like that. So, what topic is challenges? Right. So I just want to give you a brief introduction. So Krista mentioned that already. So I started working in Rwanda 12 years ago with the Human Resources for Health HRH program with the ministry. So that's a program that helps us to basically partner with the Rwandan local health workforce people to build up the capacity. So I was working with the Ministry of Health. And then later on, when UGHE, University of Global Health, opened in 2015, Paul Farmer recruited me and then joined UGHE. So it's been 8 years going on. So these are the countries that I lived in and worked in before. A short background. So I work in, so I got my education at Yale and I work at Yale for quite some time doing hospital management, and that's my background. But over time, and you can't actually do hospital management without touching the health system. And then I worked with a lot of government health systems before. So I was working in Panama and Trinidad and Tobago on a couple of different hospital projects. And I opened a couple of new hospitals in Middle East, Indonesia, and Egypt. And in Ethiopia, we started the Ethiopian Health Management Initiative and worked in Tanzania for the National Supply Chain Program. And now I've been in Rwanda for 12 years. So before we start, I want to do a quick poll. Would you do this? If you have malaria, will you take this lemongrass cocktail as a treatment produced in Uganda?
Is that the only thing I get to take, or can I
Yes.
take other things?
The question is yes or no.
Yeah, sounds good. Okay.
Sounds good? You're comfortable that you will be cured?
No.
Then why are you taking it? All right.
I was like, no, either way.
Put the second part of, all right. Second question. If you have a HIV opportunistic infection, will you take this plant extract, which is like a herbal medicine? It's natural. From Kenya.
Mark
See the data.
tells me.
It's natural. You're in California. Come on. All right. So it doesn't matter whether you take it or not, right? So we'll keep that later on. So, UGHE opened in Africa, in Rwanda. So the premises of UGHE is because we have a lot of disease burden compared to before. But at the same time, we really do not have a lot of health workers. So we have a severe shortage, and the shortage projects to go higher. So based on these premises, Dr. Paul Farmer here opened the university there with the single idea of building up the capacity. So if you do not know where it is, so we're in North America right now, moving towards Africa. Rwanda is a tiny little country in the Eastern African area. And if you go to Rwanda, you land in the airport in Kigali, which is the capital city of Rwanda. And UGHE is about 3 hours driving distance north of Rwanda. And this is the picture of the neighborhood of UGHE. It's a very rural area. So you guys went there, there's literally, you're in the car for 3 hours, don't see anything else except dirt roads, right? So that's the reason we put the university so far away from civilization. Part of that is to punish the students. Part of that is to build the capacity of the community. I just checked out the history about Stanford. It's 188 years old, something like that. We're 8 years old actually. So when Stanford first started, probably there's not much going on in the neighborhood, right? A decade later, 100 years later, it becomes the most expensive city in the world right now. Right. So there's a reason in terms of a longer term vision. Butaro, that's where we're located at. There's nothing there. If you can see, apart from the university, there's literally nothing there. That's the immediate neighborhood. So Paul Farmer's vision is to build up the community in the longer run. This is not going to happen in my lifetime, probably. It would not be something like Stanford or Palo Alto in my lifetime, but his vision is in the future, something good will happen. We're in a very beautiful place. The background over there is the biggest volcano. We're safe, don't worry. The biggest volcano as the backdrop, and there's a smaller volcanoes over there. That's the Twin Lakes in that area. So if you don't like outdoor, don't go there because this is a really nice place. And it's very beautiful there. And that's the campus. It doesn't look like anything near in the neighborhood. So we have a very modern buildings there. It's very pretty. So most people when they go to UGHE, they spend 3 hours on the dirt road and they see the mud huts, and then you go to UGHE, enter the gate. It's like, where are we now? Did we just take a turn to go to Australia or something? So we have a very modern campus there. High-speed internet. We have housing. All these are student housing and faculty housing, and that's the dining hall we have. But we're a small university. And we spend a lot of time interacting with the community. Part of the reason we put the university in the remote areas to interact with the community. So over the years, we take the students out doing community services, digging up a ditch to help them to improve the drainage, farming, talking to the community, or bringing in the high school kids to come to our university to play basketball with us. So idea is to inspire them, to give them an idea what the university is like. Qatar is a community with very low higher education admission rate. 0.7% of the people in that community went to university, not even 1%. So the idea of having a university there is to inspire them that they have potential, they have the opportunity to do it. So we spend a lot of time doing community services. So back to Rwanda. So Rwanda, we have 12 million population. 17% living in urban areas. So a lot of them, they're actually in the rural region. 74% they have access to water, clean water. And about 80% they have access to improve the sanitation. So still a long way to go.
Rex,
Yeah.
can I ask questions?
Mm-hmm.
So how does that compare to neighboring countries, the water and sanitation?
Pretty much. Yeah. DRC is a little bit worse. Uganda and Rwanda are pretty much the same. Kenya is a little bit better, but Kenya is a huge country too. So there's some area that are much better than Rwanda. Health data, fertility rate 4. Maternal mortality 248, pretty high. It's been coming down over the years. Infant mortality 26 per 1,000 life birth. Life expectancy is 69 right now. 12 years ago when I went to Rwanda, it's somewhere around 40, 50. So it improved significantly in the last couple of years. So actually, technically, 12 years ago when I went to Rwanda, I should have been dead by then. I would have passed that age. 73% literacy rate. And a lot of people are still living in poverty. Poverty means $1.25 per day. That's how much they cannot survive in Palo Alto. In terms of the healthcare system in Rwanda, most of them are government hospitals, public hospital, some private hospital, and a lot of them are faith-based, like the church build a place to take care of the patient. Health expenditure over the years has been more or less stable, around 7%. Do you know how much we spend in US?
20.
Something?
19.
Somewhere around.
And some I should know, the payment lecture, but you taught.
Over 80% have insurance. So in Rwanda, we have this national insurance called community-based health insurance. It's provided by the government. So you pay $3 per person, then you're covered for the whole year.
That's an annual fee, $3 per year.
Yep. $3 for them is a lot of money.
Yeah, sure.
Yeah.
Question, how is that funded otherwise? I'm assuming the $3 per year doesn't cover the whole.
It doesn't.
How is it funded?
So it's funded by a lot of different mechanisms. So in Rwanda, the government tax a lot of different industries to contribute the money to the insurance fund. So petroleum,
Okay.
cell phone. What are the companies? They're parking. Like if you park the car, a certain amount of money goes into the health insurance. So they're building a lot of different policies to tax the private industry a little bit to contribute. Still not enough, definitely. So I mean, healthcare is never enough. Like the money going in is tough, like a bottomless, refillable beer situation, right? We have severe shortage of human resources in terms of healthcare. Just about 1.6 beds per 1,000 population, less than 10% of what we should have in terms of the doctors, and 1.2 versus 2 nurses per 1,000 population. So every single level we're not sufficient. And in Rwanda, the healthcare system divided by the sectors. The lowest level is the village. So in the community level, we have the village, and then all the way up to provincial areas. So we have different type of people working in different places. In the community, we have the community health workers. So Rwanda is famous for community health workers. So there are people actually coming from the village to take care of the people in the neighborhood. They have some basic training, some basic medications to do that. And then from the cell level, we have health posts, which is some basic immunization services, and then go up the health sector, district hospital, and then if there are more complicated cases, they will go up all the way to the referral hospital in the specialized for any kind of specialized surgery. So obviously, the higher you go, the more referral system that you have to go through.
Like the cell and the sector, like what is there a general sense like what capabilities those have for my healthcare?
Yep. So they have different kind of packages. So in the minimum packages, they have like a standard list of things that they can do. So in fact, maybe you can elaborate a little bit more, but if I'm wrong. So in health centers, they don't have doctors there. They have nurses stationed there to take care in charge of their own place. They do delivery. But if there's any complications, they have to refer the patients to a district hospital.
So the cell doesn't do child work, doesn't do.
The cell level with health posts usually is kind of like you have a fever, go there, give medication, some basic immunizations for the babies.
Okay.
Gordon, just to give you a sense, I know from my experience with Equalize Health, to handle neonatal care, you have to go district level and above, because with phototherapy, you have to handle comorbidities. So our devices are only, for example, district level above. Just in terms of our.
But the sector still can do routine child.
Yeah, but they're gonna do like immunization and other things like that.
One question in the chat, Nathaniel is asking, is the vision to eventually populate the university with international students? Because Rwanda has a relatively small population, although well structured and organized for the region. Can you speak to that? Or
For
do you
the
want to address
university?
it? Do you want to address that later?
For the university, we are already taking international students. We have students coming from 22 different countries right now. Actually, I saved this information for tomorrow because I don't want to keep repeating. But UGHE is a global health university. Naturally, we have a lot of students coming from Rwanda, but we also admit international students for the master program. We have students from 22 countries. Our faculty is coming from 18 different countries right now. For the medical program, we have 4 cohorts so far. We haven't graduated any students from the medical program yet because it's a 6.5-year program. For the first 2 cohorts, we took only Rwandan students because we did not know exactly what was going on the first time running the program. The 3rd cohort, we opened it up to East African students. And then the current cohort, they just came in 2 months ago. We have students coming from West Africa. Right now, we're still opening for African countries. So I mean, it makes sense. It's a medical program for Africa. So you guys can go to Stanford. You don't need to go to Rwanda. Don't take up our resources there. But we're opening for international students.
This is Butaro, a district or a tertiary hospital?
Qatar is a district. Yeah. So we upgraded into a teaching hospital, but it's still technically a district hospital. Oh, okay, all right, thanks. So basically in Rwanda, one issue about the current healthcare system is, now you saw that we're aging, people are living longer right now. Healthcare worker is not enough. So we have an aging population there. The chronic disease, just like any demographic, is transitioning into a more prevalent chronic disease status. We're having a double burden: acute diseases versus chronic disease, infectious disease versus non-communicable disease. We have a severe shortage of healthcare providers. Cost, we don't have a lot of money. It's a low-income country. And the quality of service, the performance is fluctuating, is inconsistent. So we have a lot of problems going on, just like most sub-Saharan African countries. So innovation obviously is the key to go, all right? You cannot just keep relying on the traditional method. Innovation can help to reduce costs, improve efficiency, improve health, improve care. And that's the way to go. So that's why a lot of African countries right now, just like US, are promoting innovation. Every single person you talk to, oh, we're innovative, we're trying to do something. You haven't done anything, but we're innovative. But that's the way to go. People understand the concept, and that's not a hard sell, right? Everybody knows innovation is the way to go. Innovation, you guys already know, it's not just about creating a device. A lot of times when people talk about innovation, it's like, I have to create an app. That was the only innovations that we have. But it's about improving something, whether it's the process via device or via technology. The innovation is important, but there's also come with challenges. So I'm going to give you a couple of examples that throughout the years I've been working in Africa, different countries in Africa, and how all this innovation kind of work, but how fail. The first example I want to talk about is actually from Africa, but give you some information about the background a little bit. Now, technology changed over the years. Mobile phone penetration significantly increased. Internet significantly increased. In Rwanda, GDP increasing over the years. But the expenditure spent on research, less than 1%. So you got a little bit more money, but still not enough money to invest in R&D. With R&D, innovation is very difficult. Now in Sub-Saharan Africa, apply for patent. Of 2 million in 2018 around the world, 6 of them is coming from that region. So you can see there's a huge gap there compared to any other parts of the world. So worst case is actually happening in Ethiopia a long time ago when I was working there. So a lot of places, a lot of hospitals or healthcare centers are very far away in a remote situation, remote location. So medical supply, in order to get any kind of medications, they have to fill the form, like the inventory report, and then they physically have to take the report to the central. And the central will look at the report, it's like, I need to give you 5 pills now, and then take the pills back. Now, a lot of times the roads are not happening. It's like flooding, it got washed away, or it's just impossible during the rainy season. It happens all the time. So if the report fails to reach central pharmacy, then stop out, you're out, right? So a couple of years ago, well, that was probably before some of you were born. So there was an NGO. Back then, the cell phone just started. Have you seen this phone before? Some of you, okay, in the museum. So we saw that, right? And actually in Sub-Saharan Africa, a lot of countries, a lot of people are still using this candy bar phones because smartphone is there, but it's still not very prevalent. So what they want to do is like they create this embedded form in the SMS system to text the information. So the idea is once you send it stock information, you don't have to travel. Good innovation. good idea, right? Because of the capacity limitation of these teddy bar phones, they can only put in a couple of different forms, limited amount of information. So they use 5 drugs as the proxy to show the stock out. So that was the innovation that we had. Now, quick question. What do you think the outcome was?
There multiple choice.
No, you can say whatever you want. That's even better.
Slight improvement,
Slight improvement?
but limitations in expanding it further because of just the limitations of data that can be sent over in those packages like that.
Good, yeah, correct. Anything else? Anything you want to add?
Security.
Well, yeah,
You still have to get the drugs to the person.
they still have to get the drug. The information is there, but they still can't get the drug. So the outcome is they still have stock out.
Oh,
Like the whole process of training people, doing all this, setting up the whole system, they still could not get the drugs there, right? So that's one part of it. But even sending the information over there, there are multiple issues. People are not familiar with the cell phone. Back then, remember, people working in the village, they have never seen a cell phone before. Asking them to key in all those information in a very tiny keypad is very difficult. No signal. It happens to a lot of places, right? So for you guys to imagine, I can't get a signal, it's probably like hiking deep into the redwood forest, right? But in a lot of places in sub-Saharan Africa, cell phone signal is all very, very challenging. And then also, because you only have 5 drugs. So for the rest, you still have to do the paper. So you actually create more work for them. You have to do one system to text the information there. You have to keep the same system. And then you still have to send all those paper on a regular basis. So actually, we duplicate a lot of work for the people there and eventually in work, right? So I just want to show you this as an example of like a lot of times people thought, okay, the technology works here. And it's a good idea in the head, right? But without understanding the local environment, it's very difficult to actually make an innovation work. The second one is actually happening in Rwanda right now. So in Rwanda, unfortunately, we have a lot of car accidents because we rely on motorcycles to go around, and then people drive pretty fast. So a lot of times when they have an accident, the ambulance have to navigate through the complex road system to go to the accident location. And the street names is not very clearly marked. And even though they have street names, if you ask me, tell me the name of the street, I would not know where it is because it makes no sense to me. Just like coming to Palo Alto, if you tell me go to what street, I have no idea. Google Map doesn't work there. So because of that, just navigating through all the streets, try to find out the location, it adds another 5 minutes to reach to the accident site. And there are a lot of times that traffic jam. That adds another 10 minutes to reach the patient. And there are a lot of times once they pick up the victim, they go to the hospital and then they realize the hospital is full. They don't have any capacity. And then they have to divert and go to a different place. Now, that and another 30 minutes there. We did a lot of research on this so that this is the average time. And then they create this new proposal, this new system. So we have a central dispatch system. So whenever there's an accident, they call this dispatch system using the mobile phone. And then they will send the GPS location to the ambulance. And then at the same time, they can control the traffic lights. So give a green light to the ambulance wherever they go to avoid traffic. And at the same time, they call the hospitals and find out which hospital has the bed. So by doing this, the central dispatch system can help to reduce the time, so save the patient faster. All right. Do you think it has value? I mean, the answer is simple. It has value, obviously, right? How do you think the result is?
chaotic.
Why?
Depending on one person to try and manage all of that quickly can be difficult. Put it lightly.
Okay.
Like,
Well, I mean, obviously, the central dispatch is not meant by just one person. Right?
But
It's just
per
basically
call.
the system.
It kind of depends on hospitals having bed availability in like some kind of digital format that can be, so you can know that.
That would be the next level, right? If you already have a digital system to
Yeah.
report the bed system, the bed availability.
Not enough ambulances or?
In the city, we do have some ambulances. So this project is it's been going on for 10 years. I've been involved in this project for 10 years now. It still hasn't really taken off. Part of the reason is, should the Ministry of Transportation be in charge, or should the Ministry of Health be in charge? So there's internal fight among the ministry. That's like, I should be in charge. Now, technically, from our perspective, anybody wants to be in charge is fine, right? But the moment people want to be in charge, they also don't want to do the work. So there's a lot of this kind of like debate involved. So it's been going on for a long time, and it's kind of like not really moving forward. So the reason I want to show you this example is a lot of times when it comes to innovation, when it comes to a good solution, the idea is there, right? But stakeholder involvement is always important. And a lot of time, we partner with a lot of different organizations. Sometimes it's in California, sometimes it's in New York. And people always say, oh, we have these excellent ideas that we came up with, and we want you to implement in Rwanda or in Ethiopia. None of them, they ever been to Rwanda. They had no idea what it's like. And then they said, oh, this is a good solution for you. It's good for you. You should do it, right? So this is an example of our understanding what is the value. And then they never engage the stakeholders to talk about all this. And it's just an example of some of the challenges that you have. You may face when it comes to developing countries. The last one is very simple. In Saudi Arabia, I used to work there in the early 2000s. So back in the hospital, they're using paper-based for pretty much everything, particularly for building. So it's a very simple system, right? All you need to do is just create a database, put in the information. So that's exactly what we did. So we introduced a computer billing system so that you can reduce the error, reduce the time. That's a no-brainer. So we created this system for them. Everything is pre-populated in the system. So all you need is click, drop and click, right? And we even changed it into Arabic so that there's no reason for them not to use. And they still refuse to use it. So people there, they actually did not use it. So take a wild guess. It's accurate. It's faster, but they refuse to use it.
because they didn't develop it themselves.
Not that reason. But part of that is yes, because if they developed it, we would have avoided the problem. Yeah,
It's a religious cultural thing.
it's a cultural issue. So in Saudi Arabia, they use Arabic. Arabic reads from right to left.
Oh,
We use left to right, right? So it makes sense for us to have the drop-down menu, the button on the side. So for them, having a button on the opposite side, it doesn't make sense because particularly like they also associate right hand and left hand. They're very clear about right hand, left hand, one side is clean, one side is dirty, right? So putting a button on the opposite side is a no-no to them. It's a cultural thing. So we have to move the button to the opposite side. They program everything in order to make them use it. So this is a simple fix, but I want to use an example to show you like, you also have to consider the culture of the local environment. Sometimes the solution is definitely working. It's clear, it's a no-brainer, but simple things like this can break the whole project. So whether it's an environmental factor, the stakeholder issue, or the cultural factor, so all this come with some kind of challenges.
Can I ask you a question there? I think this is a really great example of like user interface and testing. In this particular case, did you launch it without doing any user testing, or do you think this could have been caught with some kind of user testing?
Well, I mean, we caught that when we test in one department.
Yeah.
Yeah, I mean, we couldn't figure out, it's like, why we didn't use it, because
Yeah.
we put it there, just assume. I mean, really require no training, right? We just put it there, assume that people will use it. 2 days later, we came back, they were still using the paper system. It's like, why not using it? And then people initially would not even tell us why they wouldn't use it. We just thought that maybe it's too difficult to use or it's not accurate. So we went back and just to test it, and we timed ourselves. We did everything we should be doing. We still couldn't figure out what's going on until somebody is willing to tell us about the whole cultural issue there.
And maybe that's a great question, is like, how did you get somebody to tell you? Like,
You have to find somebody they trust you enough to tell you, they're willing to tell you. Yeah, it's a tricky thing when it comes to culture, right? Everybody says we have to be culturally sensitive, but how to be culturally sensitive, nobody actually knows. And different culture, the cultural sensitivity definition is different, right?
thanks, Greg.
Yeah, so just a summary of what challenges that we have. I just give you 3 examples, right? But a lot of time when it comes to innovation, people are always chasing after the shiny things. Like these days, I think AI is the hot topic. Everybody's like, we have to do AI, right? But people tend to forget, like, just even changing the process is an innovation. Only because it's the trendy thing doesn't necessarily translate into something that works. So that's created some kind of innovation bias. Whatever we do, we have to do something because that's the trend. 3 years ago at UGHE, we ran a hackathon. That hackathon is just very open. We pose problems there and then let people try to come up with different solutions. For some reason, there was one of the moderators that we created. So he was very much affiliated with this tech company creating apps. So his presence alone influenced everybody thinking that they have to create an app because he was there. So every single project came up with an app. And it was relatively boring, but bias exists. I heard this all the time, particularly when you're working in developing countries. You work in my country. I come here, brought my solution here. It's like, it worked there. The moment you hear that, you know it's going to fail. And it failed not just from the innovation perspective, from working perspective too. Every year we receive a lot of expats coming to Rwanda to work there. And then you can tell this person is not going to pass the 3 months mark. He's going to leave. Because they were not willing to change the mindset. It works there, it should be working here. And we heard it over and over again. So that's part of that is not understanding local context, not understanding the culture, right? The infrastructure, the environment, all these are part of the factors. Having a solution in Australia, in US, doesn't translate into it works in any other countries. Humanitarian system. This is a classic global health work situation. We have a lot of different donors, USAID, the World Bank, the World Health Organization. Everybody is doing a vertical program. We are treating malaria here, and somebody is contributing money to treat HIV. So the malaria, we have our own registration system, our supply chain system, our medical record system. HIV, you have the same thing. So for a healthcare provider working in a hospital, I have 5 patients here. One is malaria, one is HIV. I have to do 5 different systems to take out the patients sitting in front of me. It's a lot of work. And we create a lot of unnecessary duplicated system for the people there. The intention for every system is good, but the stakeholders, they don't talk to each other a lot of times and they create a lot of unnecessary problems there. And then at the end, everybody going is like, why are you not using my system? Because I have 4 other systems to take care of, right? And then at the end, nobody uses anything. And it happens a lot. And money issue. Money is a big issue here. So in global health setting, a lot of times when funder put out some kind of proposal request, And it's according to their agenda. Now, this cycle, we want to do water and sanitation. So if your country has a malaria problem, you cannot apply for that grant. Well, maybe you can if you twist this. Water issue, right? But you have to follow the funder's cycle. I mean, unfortunately, when you need money, when you're depending on other people, you have to do that. Or the funding timeline doesn't sync with the funder's timeline. It happens all the time. But the biggest problem actually is a lot that is still have this like neo-colonialism mentality here. So a lot of the funders, if they're coming from Europe, from US, they mandate to have a European partners or US partners to apply for the grant. Or worse, the situation has been improving quite a bit, but maybe even 5 or 8 years ago, a lot of the grants, they only allow US company organizations or US organizations to apply. If you're not from that region, you're not even allowed to apply. Now, let me give you an example. This is one of the RFP. So they're calling for proposal to work in Kenya. Only UK registered organization can apply. Just by reading, like right now you're reading it, it sounds ridiculous, right? So no Kenyan can apply. You have to be based in UK. This is another one. I actually forgot which funder is putting it down. So the research is about foreign country research, but the whole research has to be done within US. I don't know who wrote that.
NIH.
Oh, I did not say that.
It says it.
All right. So funding is always an issue.
Rex, I'm so glad you brought this up. I do want to mention for those of you interested in health equity, we talk about how you have to move the funding conversations way up in the biodesign process. And Rex is really hitting on this, right? Because if you're working on a project that is not aligned with the strategic objectives of the funder, like you may be dead in the water with your project. So as we talk about health equity, and for those of you guys who are interested in that, there are a few things in our process that we have to move around, bump up, like, and we think based on these very real constraints that Rex is highlighting. Thank you.
I mean, it depends on how much you're willing to compromise, right? So some changes, some discussion has to be done, right? If it's completely deviated from your project, then you can't be applied for it. And then if within your parameter, maybe you kind of change your priority a little bit so that you can fit into the funding cycle, fit into the funding requirements so that you can get support. And then later on you can expand. But funding is always.
I mean, our experience with our East Africa program, which is our partnership, was our funder. A non-negotiable requirement was the primary recipient of funds was in Rwanda.
Yeah.
Yeah, and so we were a sub-recipient, so we're a sub-grantee, so we're that's kind of how we set it up. That's a requirement of the Gates Foundation. I don't know how many other aids work.
Yeah, it's been changing a little bit now. So as I say, 5 to 8 years ago, it's almost like if you're not coming from, if you don't have a US partner, you cannot
But
apply.
really swung
Yeah.
in that case for that organization.
So that's part of like the what Partners in Health PH has been doing, advocating for resources going directly into the low-income country rather than channeling through all the different partners. And the HRH program happening in Rwanda started 12 years ago, and that was one of the pioneer in having this kind of funding mechanism. Money directly go to Rwandan government, and then they subcontract back to the US. So since then, it's been changing quite a bit, but it hasn't been the case for a long time. Recently, I was talking to one of the universities. Actually, they want us to be the partners. Actually, it's in California. The university was in California. They want us to be the partner, and then they said, we will apply for the grant, and they will get a 70% overhead. And Rwanda, we're only allowed to get 8% overhead. So the moment it says like, why you get 70%, we get 8. You're not talking about 17% versus 8 is 70% versus less than 10% for us. And they said, oh, we're doing a project on equity. So obviously their partnership did not go well. But in the past, a lot of funding mechanism, it was kind of like that. It's heavily favoring the US institution or European institution. And Gay Foundation is one of the foundations they're actually making a very strong effort in changing it. Like our grant together, they mandate US institution can only get 10% overhead. Like 10% overhead, and we can get 15. So that's the one of the few organizations that actually balance the scale a little bit. But still a lot of funders, when they do all these kind of things, they still using the same method. 40% to a US institution, and maybe we can get 5%, 10%, something like that. So the money is definitely a big issue. Sorry.
Yeah, I had a question about foreign NGOs coming to work in Rwanda, and I was reading somewhere that they have to align with district level priorities, that they have to check in to make sure that to your point about what does a funder want versus what does the government have in their priorities? Is that true? Does that really work on the
Well, it
ground?
depends on how strong the government is. So I guess when I first started doing global health, that was like 30 years ago. Basically, who has the money, who has the power? So let's say Yale got a grant, and then Yale will come in and say, I got this money to do malaria. Will you take it? Will you partner with us? Even though you have malaria, but you need the money, you would just say yes, right? I mean, it's an example. Nothing to do with Yale, nothing to do with malaria, but that's an example, right? So that was pretty much happening in a lot of developed countries for a long, long time. And then now some governments start to fight back. It's like, I don't have malaria. Why are you coming in to do malaria program just because you have money, right? So it depends on how strong the government is. Now, the government, they do have the guts to say, if you don't align with what I want to do, you're out, right? So Rwanda has been very strong about that. Our former Vice Chancellor, Dr. Agnes Benagwaho, she is one of the strongest politicians in the Ministry of Health. So she literally say, if you don't do this, you're not welcome to my country, right? And then people start to fall in line, and then this is how they strengthen the healthcare system. Now, not everybody is strong enough to do that, right? So some countries, they're really, really desperate for money. It's just like, even though I can take a little bit, I'll let you do whatever you want to do, and I'll just take the overhead, right? Some money is better than nothing. But these days, things has been changing. Yeah. So not everybody is doing it, not every country is doing it, but we hope more countries will do this, because what's the point of having all the money going back to the NGO, not benefiting the people?
Yeah, we've been running a Biodesign program in India for the last 17 years, and it's been moderately successful. One of the reasons is that there's already a well-trained cohort of engineers, doctors who want to be innovators. So we're in some ways able to sort of pluck some of the best and brightest available. So one of the things in your presentation was 0.67% are going to higher education. Is that right? Yeah,
in our community.
Yeah, in your community. Is that a limitation to?
Oh, definitely.
And how do you address that?
That's why we have a university here. Right. So this doesn't change overnight, right? So part of the reason we are setting up a university there is to help to build the community. Development community doesn't change overnight. As I said, it's probably not going to happen in my lifetime, like literally lifetime. But we're looking in the long run. So hopefully, more and more students from the community, now they see there's a university here, that's somewhere I can go to. And that's the inspiration we have right now, but eventually it will become a fact. So and actually we already accepted a couple of students coming from the community. I think in the last 2 years, we have 4 students coming from the immediate neighborhood into the university right now. So we want, so years ago when Paul Farmer recruited me, one of the questions I asked was, actually it wasn't a question, it was my request. I said, I don't want it to be a Yale New Haven, I came from Yale. So I don't want it to be a Yale New Haven situation. Yale, big ivory tower, and the community is very poor, and then they don't talk to each other. So I made a very conscious effort to say, if that's what we want to do, I don't want to be part of it, right? So that's why we spend a lot of time going out to the community, talk to the people. Now, are we successful? Not quite yet, because the community, they can see how much resources we have just by looking at the university, right? But until somebody from the family, it's like my son goes to that university, they will never see this is their university, right? So no matter how much I say, we're here for the community, that's a lip service until their family is benefiting from the university. So we start to have 4 families right now. 4 families, they actually have kids going there, not even remotely close to what we want, but eventually we're putting it up. So hopefully in the next 10, 20 years, people will see, oh, this is my university. My kid goes there and it will be a better place. But we don't have like a hate relationship. So at least we're not in the negative side. So that's good. So the community definitely see, number one, we displayed a lot of people when we build a university. That's already a negative thing, right? And when they see the university in the middle of the night, we have electricity burning up the entire university up in the mountain, and then they have no electricity in the home. They can see that. We did not steal the electricity, but that's not the perception, right? We have running water all the time. And sometimes when you talk to the community members, they say, oh, these people, they are bringing their own tomato from US. They will say that, not the truth, obviously, right? But they see what they see, right? We definitely have a lot more resources compared to the community. So how can we make them to see that, oh, we're actually part of you? It takes a long time for the trust to happen.
But just to Raj, your question, and so we talked about the experience in India. When we decided to start a program in East Africa, we too, Crystal, were part of this. We're very deliberate that it wasn't going to be just in Rwanda. Rather, it was going to, for a second set, it would be in Kenya. Part of the reason being it's just a larger population, so it's more, it's more commercially viable to have products and attract investment. But I think the other thing we're learning is the expertise the fellows we have are going to be from, like, turns out mechanical engineering devices is really strong at this University of Uganda. So we have some really strong candidates there. And so we're seeing, and it's going to be very cosmopolitan, I guess. So we'll see how that all comes together. But it's interesting to see where the expertise lies.
I think one of our learnings was that we deliberately chose only individuals to be part of the program, and the idea is that they would be more likely to understand the culture, understand local needs, and actually stay in the community after they graduate. And that was versus having students from here.
And that's exactly Paul Palmer's vision. So we put the university in local environment. We train the people from that rural environment, so it's more likely they will continue work there. That's always the vision. Now, the only time will tell whether we can materialize that. But long answer to your question was, how do we build a community that with the same mindset to have the success that we can replicate in India? We definitely have to build a whole cohort of people that will have the same mindset, same kind of skills, same kind of vision, so that they can work together. We're not quite there yet. We just started 8 years ago. But we're getting more and more. Every year we have students graduating, and they're all around the world. But eventually we have more people coming from Rwanda with the same mindset, doing the same thing, then hopefully we'll be.
That's why we're calling it East Africa Biodesign, not Rwanda Biodesign, because our focus is broader. Now, we don't want to train folks that are going to go back to Europe or other, but that was a deliberate decision because we needed the critical mass. India, you have a large population.
That's right.
So we have that.
So another challenge, marketing commercialization. So idea is always there, right? Earlier on, I showed you like how many patents people file in this region. So a lot of times they have the items there, but they don't know how to market it, or they're not focusing on how to market it or how to commercialize them. And the first 2 questions, remember what I asked you? Cocktail. So they were both scientifically proven working. In Kenya, you probably heard about that, right? People have been using them. There's not enough marketing to let people know this is actually working. You ask, like, I want to see the scientific evidence. There are tons of scientific evidence on that. So that's one of the skills. People invent is easy, right? But sustain, doing it in a sustainable way, having it, whether it's a for-profit or not, you still have to have some kind of income to sustain it, right? So in NGO world, particularly in global health, this is one of our our major problems, because people always say we're in the moral high ground, we don't talk about money. And we just want to do good. But you still have to have money, right? So one of the things that we're teaching all the time is like you have to think about if you don't like the term sustainability, but you still have to think about how do you maintain the operation in the long run, right?
Yeah, how do people think about healthcare as a business? Like, is that?
If you ask me, I do hospital management. Healthcare is the business, right?
Yeah.
But if you're looking at
Every hospital manager thinks that, but there aren't so many.
it is, right? But if you're looking in the general global health world, I mean, this is still a concept that we really need to build into that.
Political structures, I mean, it seems like there are a lot of different ways to look at it, and so I'm curious about that.
Yeah, I mean, who is right, who is wrong, I can't say, right? Because a lot of the ways to see this issue, human life, you cannot put a price to that, right? If you put it out there, I can't really argue with you, right? That's true, right? If you save one life spending $10,000, $100,000, $1 million, you save a life, you can't put a price on that. I can't argue with you on that, right? But if you look at a program from a public health perspective, there's a reason we have a budget, right? Every single project, you have to have a budget. If you do not know how to manage a project, the budget, you cannot sustain a program. A lot of Dr. Paul Farmer's vision is like, if you have seen any of the videos that he's been interviewed in, he doesn't like talking about sustainability because life is invaluable. So you cannot put a price on that. And that's why he has me. You have to have some people to balance it out, right? So one thing Dr. Paul Farmer did really well was like, he has a vision, but he hired a lot of different people with different skills to help him to build the partners in health. So we have different perspectives and different skills to run the organization. Some people may be just like, okay, I'm here to save life. And I don't really care about operation side. You just get me what I need, right? And that's important. But at the same time, somebody has to do the dirty work, right? How to do the checks and balance. And that's why his organization has a lot of different people there.
How do you partner with?
Hang on, sorry, we have 1 minute left because I'm mindful that people need to go to town. So if it's okay, do you have a quick question or can you hold it? Okay, thank you. I know you don't want to roll it.
Yeah, just one bullet point.
Very much.
And
Oh, yeah.
this is another challenge happening in developing countries. A lot of time it's not coming from a good country, it's not good enough. I heard it over and over again. So like when you go to a hospital, we have generic drugs from the hospital because it's cheaper. And they say, oh, no, I don't want that drug.
Are locals saying that?
Even locals are saying that.
And it's not just Germany.
I know.
No, I didn't say Germany, sorry. That's why I put it in.
I didn't want you to feel bad.
So I put it in voice actually because one of my friends years ago when he went to the hospital, the doctor gave him a medication. And he kept asking, what is the medication? It's like, I forgot what the drug is. And they have this generic brand because that's what the hospital is using. It's cheaper, equally effective. But they said, oh, it's not from Germany. He actually said that it's not Germany. I'm not taking it. So we went out to the private pharmacy to buy the more expensive drug. The mindset is like when it's not coming from when it's coming from the local, it may not be good enough. So people refuse to use it. So that's some of the challenges that we have.
Can we take move around for a few more minutes for questions after people leave? Awesome. Okay, thank you all.
Thank you.
Thank you for coming.
Listen, you guys, if you're not as familiar with Paul Farmer that Rex talked about, Mountains Beyond Mountains is a good book to read. Bending the Arc is a great documentary. You know,